Welcome to the 2021 American Diabetes Association Ask the Expert series. Today's topic is, why do you need an annual eye exam? You will receive, we will give you a brief survey at the end of this session, along with a brief survey prior to the beginning. Thank you for participating. My name is Carla Cox, registered dietitian, nutritionist, and certified diabetes care and education specialist, and your host for today's program. For those of you on the phone, press *3 on your keypad, and an operator will collect your question and place you in the queue so that you may have the opportunity to ask your question live. To participate online, type in your name and question in the fields below the streaming player. Press the Submit Question button, and your question will come directly to us. Okay, now for a little bit about why we're here today. The American Diabetes Association, together with visionary partners VSP Vision Care and Regeneron Pharmaceuticals, is focusing on an often overlooked but costly and devastating complication of diabetes, vision loss. This eye health initiative focused on diabetes provides tools and resources for people with diabetes to learn how to reduce their risk of developing eye disease by managing glucose values and getting an annual comprehensive dilated eye exam, even if symptoms are not at present. And that's an important point. As part of the initiative, the ADA is holding this free educational Q&A. We'll cover information and tips to help you take charge of your health. The health and safety of all those we serve at the ADA is always our top priority. The CDC has determined that COVID-19 is a serious public health threat. In general, people with diabetes face a greater risk of complications when dealing with any viral infection, particularly if glucose has been running high prior to the infection. In addition, glucose is more difficult to control during an illness of any type. The ADA encourages you to get vaccinated, and if you have any questions about the vaccination, please talk to your healthcare provider. The ADA encourages people with diabetes to follow the guidance of the CDC and to contact your medical provider if you suspect that you are showing symptoms or have been exposed to COVID-19. For our most up-to-date information, please visit our website at diabetes.org/coronavirus or call 1-800-DIABETES, which is 1-800-342-2383. As I stated before, we're going to start with just a few short questions, if you could please answer them. Before we start opening up our Q&A with our expert, we would like to ask you these questions. Please click on the box that best, please push the number that best answers the question, and you will see the total results on your screen. Keeping glucose, lipids, and blood pressure in target range reduces the risk of developing eye disease. Press 1 for yes, press 2 for no, and press 3 for I don't know. Once again, the question is, number 1, keeping glucose, lipids, and blood pressure in target range reduces the risk of developing eye disease. Press 1 for yes, press 2 for no, and press 3 for I don't know. Question number 2, how frequently should a person with diabetes get a dilated eye exam? Press 1 for every 6 months, press 2 for every 1 to 2 years, press 3 for every 5 years, press 4 for only when the vision is affected, and press 5 for I don't know. That question again, how frequently should a person with diabetes get a dilated eye exam? Press 1 for every 6 months, press 2 for every 1 to 2 years, press 3 for every 5 years, press 4 for only when vision is affected, and press 5 for I don't know. Question number 3, true or false? Diabetes-related eye diseases can have no visual signs or symptoms. Press 1 for true, press 2 for false, and press 3 for I don't know. Question number 3 again, true or false? Diabetes-related eye diseases can have no visual signs or symptoms. Press 1 for true, press 2 for false, and press 3 for I don't know. And our final question, number 4, to what extent do you feel confident that you can reduce your risk for eye-related diseases? Press 1 for not confident, press 2 for somewhat confident, and press 3 for very confident. That final question again, To what extent do you feel confident that you can reduce your risk for diabetes-related eye diseases? Press 1 for not confident, press 2 for somewhat confident, and press 3 for very confident. Thank you for answering these questions. And now I am very happy to introduce our guest for today's event, Dr. Gershon. Dr. Gershon graduated from Indiana University School of Optometry in 1997 and completed his residency concentrating on low vision and ocular disease. He sees primary care patients and has an emphasis on retinal care in his practice in Kansas. Dr. Gershon, why don't you tell us a little bit more about yourself?
Yeah, so thank you for having me, and thank you to everyone that's on tonight and spending part of your evening with us. So I'm in a private practice, and I'm lucky enough to work with a nice group of both optometrists and ophthalmologists. And what we do primarily is see people for routine eye exams. And as one might imagine, a fairly high percentage of my patients are people living with diabetes. So this is a topic that is something that I talk about with patients every single day.
Perfect. Thank you, Dr. Gershon. As we are waiting for our questions to begin rolling in, I'm going to go ahead and kick off with the first, maybe most important question. How frequently should a person with diabetes get a dilated eye exam? And why do you recommend that?
Yeah, so great question. And let me start with kind of the analogy of what a dilated eye exam is. And I'm going to kind of take a step or two backwards first to then get to your question. So when a dilated eye exam is done, the primary purpose of the eye dilation, or the pupil dilation, is to allow better viewing of the retina. And one of the very common complications of diabetes is something called diabetic retinopathy, where the retina, or the back layer, or kind of the film in the eye, so to speak, is affected, where the blood vessels in this layer are affected. So a dilated eye exam allows us to see that part of the eye much better, much more clearly. And so how often is a dilated eye exam needed or suggested or recommended? So first off, anytime someone is diagnosed with type 2 diabetes, then at diagnosis, a recommendation should be made for a dilated eye exam. Because when someone's diagnosed with type 2 diabetes, they've likely had it for a number of years, and it may already be affecting their eyes. Once they've had that initial examination, if everything is normal, then every 1 to possibly 2 years, but certainly not longer than that in between visits. If somebody does have some changes in their eye due to diabetes, if they have diabetic retinopathy, then oftentimes the interval in between visits will be shorter. So some people as short as every 3 months for examination. And sometimes people actually need treatment, in which case they're likely to be seen even more frequently than that. So I guess the answer is there's not a super simple answer to that question, except for everyone with diabetes needs to have regular, routine eye care, and more often, if told by their doctor that there are any complications in their eyes.
Okay, thank you. Nothing is ever simple. So we're going to go to Francis. Francis in Western New York, you're on the line.
Yes. Hello?
Hello.
Yeah. Hi, Francis.
Hello. Yes, I am calling for my husband. He was, through last year and this year, he's been, well, of course, diagnosed with glaucoma. He's had the other eye, the cataract surgery, and they performed a BLEP procedure. And it seems like after he's had the BLEP procedure, his right eye lower lid slips outward. And then they diagnosed him with a corneal wrinkle, which they didn't really explain what a corneal wrinkle is, and said something about older age and plastic surgery.
All right. Sounds like a lot going on there.
Yes.
Yeah. So let me kind of take different pieces of that and see if I can address maybe what some of the questions or thoughts may be. So glaucoma is more common in people with diabetes, and so it's not uncommon or unusual for someone with diabetes to also have glaucoma. Now, just because someone has diabetes certainly does not mean they'll develop glaucoma. The vast majority of people, even with diabetes, do not develop glaucoma, but it's not uncommon at all. And then you said you had cataract surgery, which is, when my patients tell me they have a family history of cataract surgery, what I say to them is, congratulations, you have good genetics, because if you live long enough, you will develop cataracts. That may or may not ultimately need surgery, but cataract surgery for most people is fairly simple, generally is very beneficial to vision. And as it turns out, for someone with glaucoma, cataract surgery alone can generally be helpful in lowering the eye pressure in glaucoma. Now, it sounds like maybe what you're saying you had at the time of cataract surgery also was something called a BLEB, B-L-E-B, and that's a type of glaucoma surgery to help lower the eye pressure even further than just regular glaucoma surgery would. And then the last thing that you brought up was a corneal wrinkle. And what I'm not sure is if it was a corneal wrinkle or if it was a wrinkle in the retina or in the macula, which is also fairly common. If it's in the macula, it's kind of like a little, just like it says, a little wrinkle in the retina, where instead of being smooth, it's a little bit wavy and can create slightly distorted vision. If it's on the cornea, there are some conditions that can cause the surface of the cornea to be a little irregular. However, when the cornea is a little bit irregular, generally it has very minimal, if any, effect on vision. It's not painful in any way and is not due to diabetes. Now, the good news, even with all these different conditions that you brought up, is that, what you didn't tell me that he had issues with was diabetic retinopathy or diabetic macular edema. And so from what it sounds like, everything that you brought up either has been or is treatable and really should not cause any real harm or decline in vision.
Okay, thank you. That was answering quite a few questions. That was great.
Right.
So the next one on the line is Daniel. Daniel's from Washington, D.C.
Hello.
Daniel, there you go.
Hello.
Hi, Daniel.
As I was explaining to the message taker, I'm being seen by a retina specialist and two ophthalmologists and an optometrist. And I had a cataract back in 2013 removed in the left side. And I wanted to follow up with a cataract on the right side as well. But I went to my retina specialist on a referral, and he said that he wanted to inject medication in the retina, and I shouldn't have a cataract. Taking care of for the time being. But he couldn't help me to the extent that he would describe, what the procedure was. But I didn't have any issues about the injection, but he couldn't tell me, what he was using for the medication. And he said if one doesn't work satisfactorily to his judgment, he would try two others. But I called my cousin over in San Francisco, and he said he should have, because the two of them went to school, they went to medical school together, and he said that I should get a thorough evaluation of what the medication is, side effects and contraindication, and also I'm also on a regimen, and I'm a type 2, and I also I have questions about the retina diagnosis. So I've been putting off my cataract to the right side, and somehow or another I can't get the retina specialist to give me comfort and encouragement, to follow through with the AMD, which is age-related macular degeneration. They said somehow or another they have to provide care for the retina, and they gave me a test, and it was just like a vertical and a grid, and a horizontal grid, and I had the squiggles. They claim I was out of range on the squiggle test. I don't know what to do because I can't keep putting my right cataract off because every time I go for my exam yearly, looks like my vision is getting to the point in the right eye where it cannot be corrected with a prescription. Thank you.
Okay. Thank you. It sounds like one of your questions is maybe Dr. Gershon, you can clarify what kind of medication they would put into his eye and maybe triaging what is most important at this point.
Yeah. So again, it sounds like a number of different things going on from what you relayed to us. It sounds like there's an issue with a cataract, some diabetes-related changes along with macular degeneration. So I guess part of the good news is that the medication used for diabetic retinopathy or swelling called macular edema and the medication used for macular degeneration, if someone has the wet kind of macular degeneration, is the same, or the treatment is the same. And as you pointed out, the treatment is injections into the eye, which to someone that's never heard of that or had that or really read about it, it's something that sounds terrible. But the reality is people that have had that done, if you ask them, they'll tell you it's really not a big deal, that the injections are really painless. And the worst part about it is the anxiety when someone tells you what you need to have done and not the actual procedure. Now, as far as the medication that's used for the injections, there's a class or type of medication. And I'll tell you what it is, and then I'll explain it to you. The class of medication is called anti-VEGF, or anti-vascular endothelial growth factor. And what we know is that it's this vascular endothelial growth factor that in macular degeneration causes abnormal blood vessels to grow and bleed, and in diabetes causes either abnormal blood vessels to grow or blood vessels that are there to become leaky and create swelling. So this is the type of medication. And what most retina specialists do is they have there are now 4 that are FDA approved and a 5th one that's also used. So there are essentially 5 of these medications that can be used through injection. And generally an ophthalmologist, a retina specialist, will have a favorite that they tend to use the most, that they think works the best for their patients. And so they'll generally start with that one and generally do 3 injections a month apart. So the first injection, wait a month, do the second, wait a month, do the third, and then a month later evaluate if more are needed. And generally at that point, after the 3rd injection, if they don't see some real benefit, is when oftentimes they'll switch to one of the different medications. So I think what they were trying to say is that they have a favorite, or I shouldn't say favorite, but they have one that they believe works the best. They would try that first, and if it wasn't showing to be valuable for you, to then switch to another one. And this is a very, very common way to go about it, because as you can imagine, not everybody responds the same way to every medication. So what may be best for one person may not be best for another person, which is why there's not just, at least at this point, there's not one clearly better medication. They all seem to work very similarly, and there really does not appear to be one that is head and shoulders above the rest. There's been some studies that in a very specific subset of people or certain conditions that the medication called Eylea may be a little bit better. But for the most part, they're fairly equivalent. Now, the other thing I guess I'll address real quickly in your scenario was about cataract surgery. And people with diabetes absolutely can and do have cataract surgery. People with macular degeneration absolutely can and do have cataract surgery. The one thing to be aware of is if someone has a decrease in vision because of the diabetes-related changes or the macular degeneration-related changes, then cataract surgery may not seem as successful. That it may be the macular degeneration or diabetes that's causing loss of vision more so than the cataracts. So that's why both things need to independently be addressed.
Great. As a reminder, for those of you on the phone, press *3 on your keypad and an operator will collect your question. And if you're online, type in your name and question in the fields below the streaming player. Press the Submit Question button and your question will come directly to us. Now let's remember that our topic today is eye health. Okay, we're going to take a question from Alexis. Alexis, you are on the line.
Oh, perfect. Thank you. I've just recently been diagnosed as a diabetic, and so I went and I had an eye exam with my ophthalmologist. Now, he did not do a dilation, but he says I have macular degeneration and the start of cataracts, and didn't put me on, all he put me on was Preservision, the ARED 2, and said to come back in 6 months. He didn't really tell me how bad the macular degeneration is or what's causing it. Is it diabetic related? I'm also taking Vascuzyme, which is to help dissolve fibrinogens in my bloodstream. And so I don't know if that is affecting the macular degeneration or if I should really seek a second opinion with, what did you call him, a retinal specialist?
Mm-hmm.
So that's kind of where I'm at. Like a lot of questions and no answers.
No, that's okay. That's what you're here for. So no, I'm glad you asked that, Alexis. So, so the good news is that you don't have diabetic retinopathy, and studies show that somewhere between about 20 and 40% of people, when they're newly diagnosed with diabetes, actually already have changes in their eyes from diabetes. So the good news is it sounds like you don't have that. Early cataracts, again, cataracts are a very normal age-related process. They don't get better on their own, and very oftentimes, usually, ends up where someone will benefit from cataract surgery and really do really well. So then the last piece of the puzzle for you was being told about macular degeneration. And I would bet that that if you went to an ophthalmologist because of having diabetes, that they dilated your eyes, because that would be the standard of care. And so I would assume that they dilated your eyes and may not have told you, and you just didn't realize it was happening, would be my guess, although I certainly could be wrong. Now, Preservision AREDS 2 is a vitamin supplement specifically for people with macular degeneration of at least a certain stage. It's called intermediate. So more than mild, not bad, but more than just mild. And so taking 2 of those a day, if you have this intermediate macular degeneration, is absolutely the standard of care, and what we know from clinical trials, the best thing to do. And returning in 6 months is also generally what someone would recommend, that to be seen more than once a year. So to come back in 6 months and to kind of monitor your vision in between visits. Just cover one eye, look at a grid or look at something and make sure that everything looks normal on a regular basis. Then cover your other eye and just make sure there's not a change in between visits. So that's a very standard treatment. The Vascuzyme that you bring up really should not have an effect on the macular degeneration. Theoretically, anything that is anti-inflammatory or helping blood health, breaking down fibrinogens, should theoretically be beneficial in the area of macular degeneration as well. So I see no contraindication there or reason why that would be of any negative effect. What I would tell anybody, though, is whether it's an eye doctor or any other doctor, if you go and you get an answer or a diagnosis or anything that you're not comfortable with, that it's worth at the very least asking questions of that doctor, or to seek a second opinion. And so I certainly see no harm in seeking a second opinion. Even if you get the same answer, it'll help you feel more confident about it. And so a retina specialist is an ophthalmologist that specializes in problems with the retina, whether they be diabetic retinopathy or macular degeneration. Those are the two most common by far things that a retina specialist takes care of. And they could provide you with a second opinion to make sure that you're on the right track. But from what it sounds like you were saying, it sounds like the right thing is being done, and it sounds like that really there's nothing at this point that's affecting your vision in any way. And that's the most important thing, to start being proactive before something affects your vision. So thank you. I'm glad you brought those points up, Alexis.
Okay, we're going to go to Rita. Rita is from San Jose, California.
Yes, doctor. I've always had high pressure in both eyes and have a family history of glaucoma. They finally figured out that I have very thick corneas, and that's why the readings are always so high. Does this need to be more closely monitored than every other year for the dilated tests? And will the diabetes glaucoma interface be impacted by my thick corneas?
Great question. So one of the things that's done through the course of an eye exam, like you pointed out, Rita, is having your eye pressure checked. And the way that that's done is there's an instrument that just very, very lightly touches your cornea, the front surface of your eye, and that's how the pressure is measured. If your corneas are thick, then the reading will be artificially high. If your corneas are if your corneas are thinner than normal, then the reading will be artificially low. And so one of the things we know is that people with thin corneas, the opposite of you, are at greater risk of developing glaucoma. So therefore, someone with thicker corneas, like you, is at lesser risk of developing glaucoma than someone with thinner corneas. So that's good news, actually. And, I wonder if the family history of glaucoma is actually just a family history of the same thing that you have. Thicker corneas, artificially elevated readings without glaucoma. Historically, many eye doctors treated glaucoma based on eye pressure alone. And what we now know is that eye pressure is just one of the things we can measure, and really it may or may not even be the most important factor in glaucoma. Now, what about the interface of diabetes and glaucoma? Yes, people with diabetes are more likely to develop glaucoma, but again, with your situation with the thicker corneas, I would have less concern. And then your question about is every 2 years often enough? I'll be honest, if I have a patient with diabetes, I generally see them once a year. I don't go every 2 years. And it's for a number of reasons. One, because of the greater risk of conditions, even other than diabetic retinopathy, just any condition that anybody can have. Just because you have diabetes doesn't mean you can't develop something else. And so I personally think every year is generally warranted. That every 2 years may be too long, especially if there's subtle changes that start that you don't notice. So I think every year would be absolutely appropriate. Every 2 years is on the longer side of what I would ask of my patients.
Thank you. And I think the concept of at least every year is preventative, because so much of the visual problems are not, it's not like they can't see, it's that things are happening when you're still seeing okay. So That's why the prevention is so important, and the yearly eye exam is so important.
Real quick, I just want to say that's a great point that I'm glad that you bring up, because I will tell you that over the last year and a half or so, I've seen some of the most dramatic diabetes-related changes in some of my patients' eyes that have been deferring care because of COVID, which I think I'd like to touch on for a moment. But people deferring care, and just finally coming in just because, well, it's been 2.5 years, but I'm seeing great. But then when I look in their eyes don't look great at all. They're quite sick. And so your point is a really important one, that really good vision does not mean good eye health. People can have terrible, terrible eye disease and still have really good vision. So, being preventative, just because you have good vision, doesn't mean that we don't need to get our eyes checked. Just a quick point in regards to COVID. Unfortunately, I think COVID to some degree is here to stay. And it's important for all of us, and especially people with diabetes, to continue to seek medical care, not just as needed, but as needed for routine and preventative care. And eye doctors' offices should be a very safe place to go. At least I can speak to our office for the last 1.5 years or however long it's been, that we've been very, very careful and have not had any issues. And it's important not to defer care until there's a problem, to continue with your routine and preventative care schedule in order to not wait until there's a problem, because what's interesting about eye issues is that they get caught while vision is still good. Most people do great. If something's not caught until vision's already affected, well, unfortunately, those are people that oftentimes do not do as well. So continued maintenance or routine care is vital, whether there's COVID or not. So sorry, I interrupted you to say those things, but I wanted to just kind of get those couple points out that I think are really important.
They are really important. I think there's a lot of good research showing that there's been some real negative things coming out of people postponing, including children with diabetes who are in ketoacidosis because they don't want to go in. So we just need to realize you need to go in for your routine checks. We have a question coming from Suzette online. What is a good sugar range to prevent the onset of eye issues? My A1C is 7.
All right. So what's a good sugar range? So, that's a fairly individualized, or the answer for that really is fairly individualized, just like what I think ADA or any other association would say in regards to what should my blood sugar be, that targets are individualized. And I don't say that to avoid giving an answer, but I think that's an important point to start out with up front. So what we know is that as far as eyes are concerned, and in particular diabetic retinopathy, that the things that put us at greater risk of developing or worsening retinopathy are how long we've had diabetes, which unfortunately we can't control. Once we know we have it, the clock starts ticking. The next one is blood pressure control and lipid control, as it turns out. And then very importantly is blood glucose control. So what I would tell you is whatever range you and your treating physician come up with is likely going to be beneficial in helping to prevent eye disease. We know that in general, lower is better. Most people would say that a goal somewhere between 6 and 7 as far as A1C would be very reasonable. Some people can't reach an A1C below that. It becomes dangerous to try. It could cause hypoglycemia. But if you're asking and saying my A1C is 9, is that low enough? Then generally the answer is no. And that's an easy answer. But if someone says my A1C is 7, that's kind of on the top of a normal acceptable range, at least for most patients as decided by their doctor with individualized targets. The other thing I want to bring up real quickly, though, when you talk about blood glucose ranges, because the word range was used, is a different term or way to measure blood glucose, and that is time in range. And so if you use a continuous glucose monitor, you'll be familiar with that term, time in range, and that's how much of the day, by percentage, your blood glucose is between 70 and 180. And without letting it get above that and without letting it get below that. For time in range, the ideal number to shoot for is 70%. So to have 70% of your day between 70 and 180 is the best way that we know to prevent development of or progression of diabetic retinopathy, but that stands true for other diabetes-related complications as well. So I know you asked about A1C, but I wanted, if no one brings it up, I wanted to at least bring up the idea of time in range as another way that is vitally important for measuring variability or ranges of what your blood sugar is.
That's great. I certainly encourage people to do that. I think the other thing about when you think of an A1C, one of the problems is it is an average. So if your blood sugar is running somewhere between 30 and 400 and your average is 130, that's still not where we want you. And that's why this time in range concept is so good, is trying to keep it in this narrower range of 70 to 180. So that was great to bring up that point.
Right.
So next we have a question from Adrian from Pensacola, Florida. And we've touched on this a little bit, but I think just that the answer would be excellent and clarifying. Adrian.
Okay.
Yes, good evening. My question is, do diabetes, do they cause cataracts?
Great question. So the primary cause of cataracts is age. However, people with diabetes tend to get cataracts at a younger age or a little sooner than people without diabetes. That's the bad news. The good news is cataract surgery works great whether someone has diabetes or not. So I know that nobody wants to, or most people don't want to develop cataracts. But the thing about it is if you do develop cataracts and they do affect your vision, then it can be fixed, essentially, with cataract surgery. And cataract surgery, I believe, is still the most commonly performed outpatient procedure in this country. So it is very common with fantastic results. And the reason I bring it up like that is I really try to encourage my patients not to fear cataracts or cataract surgery. And it's easy for me to bring it up since I'm not a cataract surgeon. It doesn't sound like I'm being self-serving. But I really do tell people that developing cataracts is not bad news. It's news because it's something that can be pretty easily / routinely taken care of. But good question. Good question.
So here's back to kind of the A1C question, and I think an interesting way of looking at it. Catherine from Hartley, Illinois. Catherine.
Hartley. Oh. Hello?
Catherine, do you have a question? Yeah, Catherine, do you have a question?
Oh, yeah. I'm a diabetic for 50 years. I have a blood glucose thing. I'm type 1, and I'm on insulin. And I had a blood sugar. I always get my A1Cs done every 3 to 4 months. It went from a 6.2 to a 7.1. And I was wondering how that affects. Should I make a earlier eye appointment? Because I go every 6 months because she's always concerned, but I never have blood vessels breaking behind my eye. And I was wondering because I haven't seen her for the 6 months, should I make an appointment earlier to do since it went up to 7.2?
Good question. So, what I love about the question is the proactive thinking and nature of the question. And that, really what you're asking is, if something seems awry, should I maybe get checked out sooner? What I will tell you is that I would go out on a limb and imagine that many people on this call are thinking, boy, I wish I could get my A1C down to 7.1. And what I want you to realize is the difference between 6.2 and 7.1 as far as eye disease, it shouldn't be enough to get you overly concerned. If you're already going every 6 months, I think that is absolutely adequate. So I don't want you to worry about that. The fact that you're asking tells me that it concerns you, and you'll likely do something about it, and you'll probably bring it back down to 6.2, which is fantastic control. And I would congratulate you on normally having your A1C around 6.2. Now, the other thing that I'll tell you is that, you know, when you say that you've had diabetes for 50 years, that started to pique my interest. And the reason is there was something done called the Gold Medalist Study. So looking at people with type 1 diabetes that have had it for decades. And what they found was if you've had type 1 diabetes, if it's been more than 18 years and you don't have any significant damage to your eyes, that the likelihood that you'll ever have significant damage to your eyes is very, very low. So the good news in your particular case is that just based on that study, the likelihood of running into any problems is extremely, extremely low. But I love the fact that you're already being preventative and seeing your eye doctor every 6 months, and I think that's more than adequate. So again, what I would say to you is congratulations on the historic good control, and what I think will likely in the near future be right back to that.
Great. So I have a question. Is there something that can be done if there are signs of retinopathy to stop the progression?
Yeah, it's a really good question. Until a couple of years ago, the answer was a pretty clear no. So what we've always known is that better control of blood glucose and blood pressure are really important and can help prevent progression. We've always known that. But that was kind of a wait-and-see approach. Do the best that you can, and hopefully things don't get worse. There have been studies fairly recently that show that the anti-VEGF medications that we mentioned earlier can actually cause diabetic retinopathy to reverse, to get better. And so it's generally not done in people with very mild change. It's generally done in people that have a little bit more severe change to prevent from getting even worse. So the idea there, or the analogy that I use, is when you fall off a cliff, then you can be put back together, but you'll never be quite the same. And what we used to only do in eye care as far as treatment was wait till someone fell off a cliff, then start treating them with these anti-VEGF medications and see how far back you could bring them. And what some doctors are doing now is we know where the edge of the cliff is. We know kind of right before someone's going to fall off. And so what can be done now is treating someone with these anti-VEGF medications before they fall off the cliff. And what happens is their retinopathy reverses or gets better and makes them less likely to get worse. So there are people now that actually get their diabetic retinopathy treated earlier with the idea of reversing it. Short of that, we don't have any other way right now that we know of reversing the diabetic retinopathy.
Great. Okay, this comes from Nancy, Volga, South Dakota.
Hi, I have type 2 diabetes, and I go in for a yearly eye exam. She takes a picture of the back of my eye. Is that the same as a dilated eye exam?
Wow, that's a really good question. So, first of all, great job to go in once a year. That's fantastic. That's exactly what I really believe people need to be doing. So taking a picture. So there are a number of different types of cameras to take the picture that you're talking about. And the idea of them is getting an image of what the doctor would otherwise be looking in to see, creating a static image that can be manipulated instead of trying to look at an eye that might be moving around. The standard of care is generally a dilated eye exam. There are certain cameras, though, that take what we would call an ultra-wide field photo. So getting a big area of the retina. And when cameras like that are used, then most studies show that it is essentially, although not quite, essentially equivalent to doing a dilated exam. However, if it's a camera that takes just kind of a quote-unquote regular picture, then it's not getting enough of the picture. So I guess the answer to the question is it's not the same. In some cases, it is essentially equivalent, though, if it's the right type of camera taking the right type of picture. But the flip side of that is with some cameras, it's really not that close to what you'd be getting with a dilated eye exam. There are some that advocate for dilated eye exams only, others that advocate for the photos only. I believe there's a place for both, as long as most important thing is having those preventative visits and having a thorough exam with whatever means the doctor is using.
Great, thank you. So we have another question coming in from Lily from Jamaica, New York. Lily, you are live.
Hello.
Hi, Lily.
How you doing?
I'm all right.
I'm have diabetic too. Too, and I'm bedridden, and the aides have a hard time trying to get me out of bed into the wheelchair because I can't sit up and I can't walk. And I was wondering, I haven't seen a doctor for a while, and I just noticing that my right eye always running tears a lot, and I'm worried,
Sure. So again, what I would tell you, the good news is that eyes that are teary are actually usually because they're getting a little dry, which sounds kind of weird, right? It sounds silly. If my eyes are dry, why is it teary or watery? It's because with the tears in our eyes, it's important to have both good quantity and good quality. And if someone has plenty of tears but they're not very good quality, we keep on making more. And we make more and more and more until there's so many that they become runny. So eyes that tear are generally dry, and it's generally not really related to diabetes. Now, would it be a good idea to have your eyes checked because of the potential for whether it be diabetes-related changes or glaucoma or just changes in glasses or vision? Obviously, that would be a good idea, but, anything or each person needs to be looked at or taken care of in an individualized way, where for you, it's much easier said than done. There are eye doctors that do home visits. So, for example, there are eye doctors that primarily just go to nursing homes or retirement areas and that are mobile, because most of the equipment that we use is pretty mobile. And so a mobile or wherever you need to be eye exam can actually be a very efficient way to check for eye problems. So that may be something that's worth asking one of your other providers about, if they know of any eye doctors that do, non-office-based exams.
But I'm so used to having, your eyes up at the machine, and they look and at your eyes and everything. And I feel like when an eye doctor comes and he just look at my eyes and everything, and he tells me I have dry eyes, but I need glasses. My glasses need to be changed too and everything. But I'm here bedridden 24/7. Nobody's not helping me to get out of the bed because nobody don't want to break their back or anything, and I'm worried.
Yeah. No, I understand, and I can understand why you would be worried. But what I will tell you is it's quite frankly not that difficult to check for glasses outside of an office. It takes a little bit of equipment, but really not so much. So there's a very good way to check for glasses. The instrument that we would use in an office to look very closely at the fronts of your eyes, there are mobile versions of that. The lights and lenses we use to look inside your eyes for diabetic retinopathy, are very easily taken from place to place. So most, if not all, of what you would need could be done very accurately outside of an office setting.
Great. Thank you so much. So now we're going to, let's see here. It doesn't want to go live, so we'll just mention Theo. And the questions from Theo are there foods or supplements that you would recommend to improve eye health?
Great question. So that's one I get asked all the time. And so luckily for me as an eye doctor, the foods that I recommend to my patients are the exact same as what your primary care doctor, endocrinologist, or any other physician would be recommending to you. So what I recommend to people are my one-liner is more fruits and vegetables, less refined carbohydrates, which if you have diabetes, you've heard many times before because that's kind of the standard of what needs to be done. In particular for your eyes, the two nutrients that I would tell you to investigate or that are worth taking are lutein, Lutein, and zeaxanthin, Zeaxanthin. So those two things are in many different supplements, many different eye supplements, and are very good for your eyes, and very good for your eyes in particular if you have diabetes. So, and there are a number of diabetes eye-specific supplements that are available. And so you can even just probably do an internet search and find some of those that are specifically made, eye supplements specifically made for people with diabetes. And so those two things, lutein and zeaxanthin, should be in that. If you want to know foods, I would tell you the best foods for your eyes are green leafy vegetables like spinach and kale. Carrots are not the best food for your eyes. If you're going to pick one thing for your eyes, spinach and kale.
Great, thanks. Okay, Ophelia Ray. Ophelia has a question.
Yes.
All right.
I'm a type 1 diabetic, and I've been diabetic for over 50 years, and I'm using a Descon now. But my problem is I've had cataract surgery, but my left eye now, it's like I'm looking through a cloud, and I'm trying to figure out why is that so. It's not as clear as my right eye. It's sort of cloudy.
Yep, that is very common. So again, having had diabetes for 50 years, if you don't have any serious diabetes-related eye issues, the likelihood of ever having them is very, very low. That doesn't mean you won't, and you still need to get checked, but the likelihood is very low. So I'm not a betting person, but if I was, I would bet on, I'll tell you what I would bet is going on in your eye that's cloudy. After we have cataract surgery, or let me explain, when someone has cataract surgery, cataract is something that's it's essentially something that's cloudy inside of a bag. And when you have cataract surgery done, what happens is there's a little hole peeled in the front part of the bag. The cloudy stuff is sucked out of the inside, and a lens is implanted in that space on the inside. What's not touched during surgery is the back side of that bag. However, very oftentimes after cataract surgery, anywhere from 6 months to years later, that back part of the bag becomes cloudy. So it's fairly common. It is a very, very easy in-office fix with a laser. So that's something that I see on an almost daily basis. That is a very, very simple fix that is covered by insurance. Even if it's not covered by insurance, it should be relatively inexpensive, and it is immediately effective, meaning you have the laser done while you're in the office, and by the time you walk out of the office, you notice a dramatic difference. So that would be my bet as to what you're experiencing, Ophelia.
Great. So another question I have is, I have heard that maintaining blood lipids, you mentioned blood pressure and glucose control, but also blood lipids is helpful in preventing some forms of eye disease. Is that correct?
Yes, so that is correct. So I think I mentioned one time earlier about lipids and cholesterol, but yes, that is absolutely important, and there are studies that show that. And again, what's nice for me as an eye doctor is I'm able to give very complementary messages to what all of your other physicians are talking about. So good blood glucose, good blood lipids, good blood pressure. And if we can control all of those, then dramatically decreases the odds of complications in our eyes, as well as most, if not all, other diabetes-related complications. Okay, and we have time for one more question, and this is coming from
Jerry Collier. Jerry, are you on the line?
Yes, I am. Sorry.
Okay.
I didn't hear you say my first name, and I said, it sounded like she said my last name. Hello, doctor. How are you today?
I'm great. Thanks for calling in.
Well, thanks so much for being here tonight. I just have a pretty mild question here to ask. I am a type 2 diabetic. I've been diagnosed for about 6 years, and I am not on insulin. I have had cataract surgery on both eyes about 9 years ago, and I do have the lens implanted in my eyes. But what I'm really calling you about is a couple years ago, while I'm under the care of a retina specialist that I have not seen him. Normally I do see him every year, but with the pandemic, they canceled the appointment. But I did see an optometrist last year to get new glasses. And she did do dilated eye exam last year. But what I'm questioning about is a couple years ago, before that, I saw a different ophthalmologist. And when he examined my eyes, he said that I had a birth defect in my eyes, and which he would not identify what it was because he was afraid he was going to throw somebody under the bus. And I was like, I'm 60-some years old. That doctor's probably dead, who examined my eyes when I was a child. But when I went back to the retina specialist, I mentioned it to him. And so when he, studied my chart, he said it was an optic nerve birth defect. And no one, and all the doctors I've been to, and my family has gone to mainly ophthalmologists my entire life because my father was blind. I have a sister who was legally blind from a child forward. And so all of us have had vision issues our entire life, but none of us that severe. So my question is about this optic nerve birth defect. Nobody was really able to explain what it was and how it would impact me going forward. So that's where my question is.
Yeah, so that's a tough question because the reality is there's a lot of different things that can affect someone's optic nerve. So that's what makes it a really tough question to know the answer to. But there are a number of different things that we can be born with that affect our optic nerve that may never affect our vision. And so if it's something that you were born with and you're in I don't know exactly how old you are, but let's say you're at least in your 40s or 50s, and if you were born with it and it's never affected you, it's not likely to ever affect you. So I think that's probably the most important thing, that if it truly is something you were born with, and by the time you're middle-aged, it's not likely to start bothering you. It's also not likely to be related to diabetes because it was there well before you ever had diabetes. And so I would tell you it's something that, oftentimes as doctors, we see things that are there that are really of no relevance. And sometimes some doctors tell patients everything, say, well, this is what I found and it's of no relevance. And other doctors may not want to bring something up that might create anxiety in a patient. And so that may be what had been done in the past. Maybe someone just didn't bring it up because they didn't want to create anxiety. But to me, it sounds like something that you don't need to worry about. And it sounds like you're already receiving routine and preventative care and that you're doing all the right things.
Great. Thank you, everyone, for joining us today. We appreciate your feedback on today's event. To provide your responses, press the corresponding number on the keypad of your phone. For participants online, please click on the poll section below the Ask a Question form and click to submit your responses. Okay, so we have just 4 questions. Number 1, keeping glucose, lipids, and blood pressure in target range reduces the risk of developing eye disease. Press 1 for yes. Press 2 for no, and press 3 for I don't know. Once again, question number 1, keeping glucose, lipids, and blood pressure in target range reduces the risk of developing eye disease. Press 1 for yes, press 2 for no, and press 3 for I don't know. While we take a moment for the next question to come up, I'd like to remind you about one of our programs supporting people living with type 2. I'd like to draw your attention to the resource the ADA has for diabetes-friendly recipes called Diabetes Food Hub. Go to diabetesfoodhub.org to find and search for recipes to try, learn about nutrition, and sign up for a newsletter to receive regular tips for managing your diabetes with food. Again, the website is diabetesfoodhub.org. Okay, for our next question. Question number 2. How frequently should a person with diabetes get a dilated eye exam? Press 1 for every 6 months. Press 2 for every 1 to 2 years. Press 3 for every 5 years. Press 4 for only when vision is affected. And press 5 for I don't know. Again, question number 2 is, how frequently should a person with diabetes get a dilated eye exam? Press 1 for every 6 months. Press 2 for every 1 to 2 years. Press 3 for every 5 years. Press 4 for only when vision is affected. And press 5 for I don't know. Before we go on to question 3, we would like to let you know that if you missed a part of today's event or would like to just listen again, we now have full recordings available on our website. Go to diabetes.org/experts and click on the past recording from all previous calls. Here is question 3. Question number 3, true or false, diabetes-related eye diseases can have no visual signs or symptoms. Press 1 for true, press 2 for false, and press 3 for I don't know. Question 3 again, true or false, diabetes-related eye diseases can have no visual signs or symptoms. Press 1 for true, press 2 for false, and press 3 for I don't know. Before we move on to our final question, we would like to remind you again that our next Ask the Expert event is October 12. Please join us. Okay, so our final question is number 4. To what extent do you feel confident that you can reduce your risk for diabetes-related eye diseases? Press 1 for not confident, press 2 for somewhat confident, and press 3 for very confident. Okay, that final question again, number 4. To what extent do you feel confident that you can reduce your risk for diabetes-related eye diseases? Press 1 for not confident, press 2 for somewhat confident, and press 3 for very confident. Special thanks to our expert, Dr. Gerson. I am Carla Cox, and on behalf of the ADA team, we want to thank you for joining us today, and we look forward to connecting with you on our next event, Ask the Experts, October 12, Prepping for Travel with Diabetes. In addition, check out our website, diabetes.org/experts, for other events throughout the year. We are sorry we were unable to get to all of your questions during the live Q&A event. If you have questions about this event, you are welcome to contact us at AskADA, that's ASKADA, at diabetes.org, or by calling 1-800-342-2383. Thank you for joining us today, and stay well.